when you're moving from the wards to discharge, that's another high risk transition, or emergency department to discharge. That's another high risk transition where we're going to say exactly what we want in an ideal world, right? Ideally, we want the person to get the outpatient MRI to follow up this tiny liver lesion. We need that outpatient MRI to really look at that in more detail. And we put in that outpatient referral to the liver specialist. And in the real world, on the clinic side, sometimes you prep the entire visit and then the patient has a transportation issue where they can't come to clinic. They have barriers. They have a family emergency. They can't come to clinic. They have an insurance prior authorization issue where
Mhm.
they can't access that medication that you expertly got for them on discharge. And I think that that's exactly what you're talking about when the real world of medicine, as imperfect as it is, kind of collides with the best laid plans as well. Dimitri's done a lot of great work with the uncertainty communication checklist as one way to talk about that very concretely. The way that I approach it in the hospital is I try to be really explicit and again, over explaining, over communicating is better than under communicating in these situations of I've placed a referral to hepatology clinic, liver clinic. They should call you within 7 days. If you don't hear from them, please call this phone number. So I try to be really explicit about what are the things in the healthcare system that we're keeping them connected, their primary care provider, a post-discharge phone call, or a navigator, patient and their family, and also giving that patient and family those tools too to say, hey, this is this is really clearly kind of our collective next steps, our collective homework, and we're going to work hard to help this happen, this workup happen. And if it doesn't happen, here's how we troubleshoot that. So that kind of takes away some of that anticipatory anxiety and troubleshoots.